Please keep decorum. There should be no noise. Friends, ladies and gentlemen, hence, welcome to CME number 886.
Good evening, ladies and gentlemen. I am Dr. Shirin, Senior Consultant Ops and Gynaecology. I run my own clinic. Already Dr. Usha has introduced herself elaborately. I will just say she is Associate Director Ops and Gynaecology, Max Smart Super Specialty Hospital, Saket, and she expertises in robotic surgeries and gynecological practices. And she will enlighten us with her expertise, operations, and in detail what are the advantages and disadvantages of this robotic surgery. There are many common surgeries that are done by robotic manner: myomectomy, hysterectomy, tuboplasties, anastomosis, endometriosis surgery, and some rare surgeries also, sacrocolpopexy and other many vaginal vesical fistula repair. She is more expert. She will expertise and she will tell what are the benefits and practices are newer in robotic surgery. It's my pleasure to invite Dr. Usha.
Very good evening again to all of you, and I'm very thankful to Dr. Shirin for kind introduction. So post dinner, I think I'm meeting to all of you third time. So how is the Josh today?
Very high.
Are we all set to travel a short journey of my topic? Today is robotics in gynae, which is, I'm sure it's going to be thrilling for all of you. So what is robotics in gynae actually? The FDA has approved a Da Vinci robotic system long back in 2005. And I have learned this robotic surgery in 2018. The moment I learned it, this became the biggest breakthrough in gynae robotic surgeries. So earlier this has been designed by Stanford Research Institute to do telesurgery, to treat wounded soldiers in the battlefield and sitting remotely. But the so much evolution happened since so far. Nowadays people are sitting in the same room, close to the patient and treating the patient. So whenever I say to my patient, would you like to do robotic surgery or laparoscopy surgery? The first question you will also ask, and they are asking me the same question, Doctor, Robo is going to do the surgery, you will not do the surgery. So the answer is, Robo doesn't do the surgery.
Ma'am, kindly increase the volume.
Yeah?
We can't hear you, or you keep the mic up.
Mic increase.
We can't hear you at the back.
Is it okay for you? So, Robo doesn't do the surgery. Basically, Robo has got three components. One component is patient cart, second is console, third is Robo arms. So, if I show you how this console is not the simple console. This is basically ergonomically designed console. We sit on the console and then we view high definition 3-dimensional camera. Earlier when we used to do laparoscopy, they're either high definition or 3-dimensional. But this has got both. And we are watching the screen with these very crystal clear view. And then with the master controls in my hand, you can see these master controls. These are the master controls in my hand. I manipulate the wristed laparoscopic instrument. So basically, the robo arm. So basically, the robo arm is mounted on laparoscopic instrument, and with the help of master control, we are manipulating the instruments. So that's the beauty of robotic surgery. Let's see what Cochrane review is telling about the robotic surgery. So they have taken they have reviewed 12 randomized controlled trial standard, and they concluded the robo arm is actually replicating the human hand. And I would say more than human hand, because we can move the robo arm in 7 directions, which the hand we can't move. And the surgical efficiency is much higher without increasing the surgical time duration. So that is the difference. And better ergonomics, because we are, in comparison nowadays, the laparoscopy surgery I started calling conventional laparoscopy surgery is a straight stick surgery, because this is very less flexible than robotic surgery. So what about I started talking all of you about all gaga over robotic surgery. What are the cons? When I talk to the patient, they ask second question to me, doctor, is it going to be in the same cost as laparoscopy surgery? So biggest con, biggest downside is the cost. Cost is patient, they are supposed to pay at least 1.6 lakhs extra than the laparoscopy surgery. But the good news is, most of the insurance company, like most of the patient, 90% of the patient which I am seeing in my OPD, they are all insured people. So the insurance company, they start sponsoring for robotic surgery, and hardly I think 1 or 2 insurance company, they are not sponsoring for robotic surgery. The patient need to shell out the money, 1.6 lakhs from their pocket. But you believe or not believe, this amount is well compensated by the robotic skills minimum cut, minimum paid. Why I am telling you minimum paid? The laparoscopy, you can argue with me, doctor, in the laparoscopy surgery I am giving small cuts, then why minimum paid in the robotic surgery? In robotic surgery what happens, actually these are the robo arms you can see. So what happens, the robotic instruments, the fulcrum of the movement is inside the abdominal cavity. It's not on the abdominal wall. So when the movement happening inside the abdominal cavity, pain is much lesser. So this is really well compensated with shorter stay of the patient in the hospital, and with robotic surgery we have got beautiful energy devices. So the difficult surgery like myoma surgery and all, then there is a fear of lot of bleeding during the surgery. With the robust energy control, you can catch hold the bleeder, and the bleeding control is superb. And there is a very high rate of being successful surgery with robo in terms of not converting into open surgery. From 2018 I have been doing robotic surgery, and I don't remember, trust me, I don't remember the single patient I had converted into open surgery. So that's the beauty of robotic surgery. Another con, if you talk about, in robotic surgery actually there is no haptic feedback. There is no tactile sensation. I am touching the bone, but I am not getting that feedback. I am touching the bone. I am holding soft tissue, but I do not know that I am holding the soft tissue. Once your vision is getting trained to that what you are seeing and doing, then that hurdle is no more there. So in the beginning when I am suturing, I do break many of the threads, because you don't know, you are not getting the haptic feedback. But once you become master of the art, this surgery is 100 times better than laparoscopy surgery. So now the question, the most important question, what all we can do with robotic surgery? Anything, everything which we can do laparoscopically, we can do it robotically, with better efficiency, with greater precision. So I am here just showing my videos. You can see here, this is a video of, can all of you can see this video? So this video, if you can see this, I am doing robotic hysterectomy with my monopolar Caesar. This one hand I have got monopolar Caesar, and this in another hand I have got bipolar Caesar, and the upper one you can see I have got the grasper. So what is special about the robotic surgery? I am not dependent on my camera person. I don't need camera person, because camera is in my hand. I can move the camera with my master controls. I don't need assistant, because assistant is my third hand, that's the grasper which is holding the tube. So I don't need assistant, I don't need the camera person, and beautifully you can do it. So nowadays you can understand, because cesarean section rate is going very high. So patients, most of the patients they come, if I treat 10 patients, out of 10, hardly there is one patient who has got simple hysterectomy. Rest of the patient they are with the previous 2 cesarean, previous 3 cesarean, and multiple cesarean, they are all more complex cases. So you can see here how beautifully I am cutting with my monopolar scissor, and this, the one which I am holding in my left hand, this is bipolar scissor. So any bleeding, little bit of bleeding, I can control it nicely. At the same time, I cut it. So this girl was just 25 years old, and she had very huge myoma. When she came to me, she was already taken the Ayurvedic medicine, hormonal treatment, and what these hormonal medicine and Ayurvedic treatment does, it does harm rather than doing the good for the patient. And the myoma is getting completely degenerative. When you see this myoma, when you can see, I'll show you, I'm just making the cut. You see this myoma. This was completely degenerated myoma, and I'm holding this tentaculum in my one hand. I'm extracting it out. So it was quite easy. If I do laparoscopy surgery for this degenerated myoma, trust me, it's going to be very, very difficult, because surgeon is sitting on the console, and here surgeon is very comfortable. So there is no eye strain, there is no standing for the long duration, there's hardly any, the surgeon is not getting tired. And very importantly, when you are sitting on the console, you can take breaks in between. You can go out, just have a cup of coffee, come back, and then you do the surgery. So it's very, very less tiring for the surgeon. When surgeon is comfortable, surgeon is doing surgery very comfortably, naturally, the possibility of having complications are going to be lesser and lesser. So you can see here how I have removed this myoma, and you see here one more patient. This one of my international patient came here, and if you all remember, whenever any patient of yours is having prolapse, sagging down the uterus, the treatment all gynecologists will tell you to go for vaginal hysterectomy. That is the simplest treatment they can offer. So surgical field has been advanced. See the size of the fibroid, how big the size of the fibroid, and she had multiple uterine fibroid, not single one. This was 18 centimeter fibroid which I had removed few days earlier, and with lot of ease. It's difficult to believe, I mean this surgery I was able to finish in 45 minutes with the morcellation. We have got beautiful endobags. We put these fibroids inside the endobag, so there is no more spillage of myoma tissue inside the abdominal cavity. So there is no upgradation of sarcoma. There is no risk of parasitic fibroid in the next time. So this, you can see, this was one fibroid I had removed, and on this side there was another fibroid. Suturing is very easy because I can suture it like open surgery. So I can move, my dexterity is very good, I can move my hand in the 7 direction, and suturing is beautiful with robo. The same sort of suturing I cannot do with laparoscopy. So nowadays the incidence of endometriosis is rising. Many of your patients, they must be coming with severe dysmenorrhea, severe menorrhagia, and they are having infertility. And when you do MRI, the endometriotic cysts are coming. But earlier again we used to do only cystectomy. But cystectomy is not the treatment for endometriosis. The problem is adhesions. Whenever there is a grade 3, grade 4 endometriosis, there are lot many adhesions. Can you see, these are the adhesions I am doing adhesiolysis with the help of my monopolar and bipolar scissor. And if you can make out the whole bowel, this is the bowel is going here, this whole bowel is going inside the abdominal cavity, the abdominal wall. So one has to be very clear, very cautious, and very nicely one has to do the dissection, because any movement you can damage the bowel. So that's the beauty of monopolar scissor. You can dissect it so precisely. The vision is crystal clear. Dissection is so beautiful. There's hardly any risk of bowel damage if you are doing it carefully. So grade 3, grade 4, any sort of endometriosis, bladder endometriosis, bowel endometriosis, you can easily dissect with the help of monopolar scissor. So what about this? Yeah. So then patients, most of the patients, they chocolate cyst in the ovary and the rectum is getting adherent to the uterus. So you have to do ureterolysis, you have to do rectal adhesiolysis, and you have to remove the complete disease from the abdominal cavity. If you are not removing the complete disease, complete peritonectomy, if you will not do that, patient will come back with the recurrence. And recurrence is really bad. So I don't only do surgery, I have started the new protocol for my endometriosis patient. I put them under monitoring. So every 6 months, I teach them how you have to monitor your symptomatology. So anytime if dysmenorrhea is coming back, dysphagia is coming back, or they are having painful periods, then I tell them to go again for ultrasound or MRI. So if the size of the endometriotic cyst is less than 3 cm, we can control it on medicine. None of my patients came back to do for redo surgery. All of my patients, I do once for all the complete radical surgery, and next time I put them on the monitoring. So these patients, many patients, they are conceiving after doing the surgery and they are very happy. So if I am doing this endometriotic surgery for infertility patient, then I just do adhesiolysis and endometriotic cystectomy, not oophorectomy. I don't remove the ovary, I just remove the cyst. So if you remove the cyst, then recurrence is hardly, I don't think I have ever seen any recurrence in my endometriotic patient. So that's the beauty of this robotic surgery. So we have all the advantages. Your patient, they can have all advantages of smaller incision, like in the laparoscopy surgery. They have lesser pain, and as I told you, the fulcrum is inside the abdominal cavity. The patient have got a faster recovery, more efficient energy system, made it the surgery of the choice for the patients and for the doctors as well. So it's the surgery of the day, for the moment and for the future. So my humble request to all of you, you have to choose it, you have to see it, and you have to use it to decide whether this is the good surgery for your patients or not. As I told you already, the most of the patients, they get insurance. Hardly, I think one or two companies, insurance company, they are not giving money for robotic surgery, but rest of all insurance company, they are ready to sponsor for robotic surgery. So use it, see the results on your own. And my humble request to all of you, please recommend to your all patients, they should be all aware about this new surgery is going on. This is the biggest breakthrough in the gynae field, and they have to choose and they have to take all advantage of this new surgery. And I'm so thankful to you, all of you are out of your busy OPD timings, evening OPD, you took the time out for me. Thanks a lot to all of you. And if you have any question or queries, I'll be happy to answer.
I would like him to be part of the discussion. What do you do, Dr. Biplab? Can you just tell the gathering?
Everything. I'm not doing robotic surgery right now. I don't have this opportunity right now. Just I am doing all laparoscopic gynae surgery.
If you have a patient who asks you that डॉक्टर साहब मेरे को तो रोबोटिक करवाना है, मैंने गूगल किया था robotic, would you like to refer your case to Dr. Usha and Kumar?
Yes, obviously robotic is a very better advanced surgery due to there is so many factors for robotic surgery rather than the laparoscopic surgeries. Like ma'am already said, there is no surgery का उसमें थकान नहीं है. They are not tired at all. They can take a break. There is no need of an assistant or no need of a cameraman also. And in my laparoscopic surgery, I feel that there are so many assistants is required. Like a good cameraman is very important. And a very good assistant also is very important for the gynae laparoscopic surgery. But in robotic surgery, surgeon is himself or herself is the cameraman and herself is the assistant using the robot. This is the main advantage. And there are other advantages of robotic surgery, like there is the movements of the laparoscopic instrument are little bit restricted rather than the robotic surgery. The movement of the laparoscopic instrument little bit restricted. The flexibility of movement of the robotic instruments are better rather than the laparoscopic surgery. And this depth of this precision is also important for robotic surgery rather than a laparoscopic surgery. Previously, laparoscopic surgery was 2D. Now it is also 3D laparoscopic surgery is there. Precision of laparoscopy is much more improved, but not up to that level of the robotic surgery because the robot, they can do the more depth of the surgery. This is the main difference between the laparoscopy and robotic surgery. We are doing routinely all difficult laparoscopic surgery, but right now I am not restricted within the robotic, and I am doing all the many advanced laparoscopic surgery.
Would you like to undertake some training under Dr. Usha and Kumar, ma'am?
I would later to have a training from Dr. Usha. Okay.
I would like Dr. Shirin Masi to start the discussion. Her perspective on what has been displayed, and then I will go to the other gynecologists. Yes, ma'am, I am coming to you. The first right should always be with the moderator. Right? So, and Dr. Shirin Masi is already angry with us not to put the sofa in time here. Ma'am, I am very sorry.
It was very crisp and short and crisp lecture, and everybody was interested to listen because it was short. There are some queries or information that I got from Dr. Usha regarding myoma surgeries. How you handle very big myomas, more than 10 centimeters, or myomas who goes beyond pelvis, or
How to reduce the bleeding during surgery. Because bigger the myoma, bigger the risk of bleeding during surgery. So you have to keep vasopressin in your hand. Again, one can argue me vasopressin has lot of side effects. The patient, they have cardiac problem, the breathing issues. We cannot use vasopressin for all patients. So what I have started putting syntocinon drip while doing surgery. Tremendously reduce the bleeding during surgery. And second thing, as I said, the robo, when you are using robo, in both hands we are having energy source. So any movement, little bit of bleeding, you can cauterize then and there, and then you can proceed. Third thing, very importantly, when you see very big myoma, always try to map it out with MRI or with your previous ultrasound, and you see sometimes the myoma is looking very big. If you have seen the video which I played, there was very big 18 centimeter myoma. But I had mapped out everything before doing the surgery with the MRI picture, and I saw there is a big pedicle down to the myoma. So if I would have started from the top to bottom, I would have taken 6 hours to create this myoma. But I had started because I had already read the MRI, and I knew there is a broad pedicle down, so I started cutting from the pedicle. So the whole job became hardly half an hour job. Only time took it was for the myoma morcellation. So that the few points, if you incorporate in your practice, that will definitely help.
one more expert input I will want. Women with urinary incontinence used to live like pathetically in earlier days, using nappies and all. Social taboo was there. But now with the robo, you have this birch colpo suspension people are doing. How successful it is, I just want your input on that.
So the women, they were coming for the incontinence. We used to do earlier. What we used to do, the transobturator tape. So that was very successful, and it's still successful. Because this is just 15 minutes procedure. I always prefer doing transobturator tape over laparoscopic or robotic birch colpo suspension. Because birch colpo suspension is a little extensive surgery. But the good thing is, nowadays the glue is available. which you put it on the paravaginal space. You can lift up the paravaginal space with the help of glue. So that surgery has also become very nice. I'm sorry I couldn't show you the video for verge colposuspension, but that is also the beautiful technique. But still, if you ask me honestly, I prefer TOT.
Now the forum is open for questions.
Dr. Usha.
Yeah.
Just one comment. After vaginal hysterectomy, wall prolapse is not so common if you ligate. After ligating the uterosacral ligaments of both sides, if they are tied together, McIntosh ligament I am talking, then wall prolapse is very, very rare.
Yeah.
We have done vaginal hysterectomy at least 40 cases. In only one case I have found wall prolapse. What we do, always we tie uterosacral ligament both sides each other after ligating.
You are absolutely right, Dr. Potera. If you do internal caldoplasty, what you are talking, this is internal caldoplasty. If you are expert person and if you do internal caldoplasty nicely, then definitely the incidence of wall prolapse is decreasing. But we never know which patient will come with wall prolapse, which patient will not come, because it depends on the level of collagen deficiency. If she is really collagen deficient and there is a weakness in the pelvic floor, whatever level you do uterosacral ligation, she will come back to you. So it's a good idea. Prevention is better than cure. If patient is willing, then put a small mesh over there. I mean, it depends person to person. If you are happy with your results, your expertise into that, then that's a very
Only thing is cost. Robotic surgery will cost at least 4 lakhs, I think.
No. The thing is, this is the biggest myth. I just want to clarify for all of you. The cost of the surgery, it's not like 3 lakhs, 4 lakhs. The cost of the surgery depends on the insurance company. There are so many, like for an example, Star Health is one of the insurance company where surgery cost is, believe or not believe, how much? Just guess. Just guess for the same surgery, how much? Sorry?
1.5 lakh.
60,000 for the hysterectomy. Can you believe? They only, even your patient, any patient who has got these policies, there are many policies. I have just given you example of one policy. There are many policies. If you go with that, the cost of the surgery is only 60,000. And if you go to any hospital, Max, Fortis, go to any hospital, no one can take away money more than that. Everything is in black and white. So, of course, if this is robotic surgery, then these people are kind enough to give you the cost of robotic surgery along with that 60,000 package. So, surgical cost is not increasing at all for the patient. It's not, of course, this 4 lakhs which you are telling, this is for the cash patient. The patient who are not having any insurance, then hospital will charge as per actuals. But if you have insurance, the cost of the surgery is depending on the insurance company. Okay?
Just a minute, Dr. Kiran. We will come to you. Dr. Rajiv, you cannot leave without asking a question.
Yeah.
You can leave, but ask a question. Ask a question before you leave.
For me, the only question is that it has a very steep learning curve, and I congratulate you that you have mastered the art. And I think for the benefit of our surgeons like Viplav here, what exactly is the best route to take to master this difficult learning curve?
Great answer.
So, is there a shortcut? Rajiv is asking.
शॉर्टकट नहीं पूछ रहा है इसका कोई शॉर्टकट नहीं है क्या बड़ा लंबा लर्निंग
I just wanted to give you two comments. Number one, the learning curve for laparoscopy is little longer. Robo is little shorter. Number one. Number two, for the Dr. Viplav, any hospital which has got Robo, he can join, he can take the training. It's hardly training, believe or not believe, the training is only for 1 day. You can clear your exam in 1 day, then you have to assist 20 cases to any robotic surgeon. After assisting 20 cases, you can sit on the console and you can do it. So that's
You can proceed with ma'am and have dinner. Thank you for coming, but please have your dinner before you leave. Thank you, Rajeev. Ma'am, yeah, Dr. Kiran, we'll come to you. Ma'am, I want to ask you a question. We now live in a world where a lot of malignancies are being addressed in a very good way, and the survival is getting prolonged. Even in stage 4 pulmonary cancers, immunotherapy has changed this scenario, and we are looking at survivals even at 5, 6, 7 years with immunotherapy. I wanted to know what is the scene with CA uterus these days, because unfortunately the malignancy gets diagnosed very late. So your comment on that, because that is your USP.
So the thing is, for CA endometrium, again 2 messages I will give. CA endometrium survival rate is very good if the patient has been caught in stage 1A and 1B. Up to 2A we can do it, and with surgically. More than 2A, patient has to go for chemotherapy first, and then we have to do surgery. So survival rate is 70 up to 70 to 80% if the surgery has been done in early stage. And with robo or laparoscopy, when we are doing radical hysterectomy, now actually the scenario has been changed. The thing is, earlier for all patients we used to do pelvic lymphadenectomy and para-aortic lymphadenectomy. Nowadays we are not doing pelvic and para-aortic lymphadenectomy for all patients. We take only sentinel lymph node. We inject the dye, we found out the best lymph node, which is draining lymph node. We take out that and we send it for the microarray examination. So if it is found to be positive, patient needs further chemotherapy. If it is not positive, we are not supposed to do anything. But of course for the higher grade, there are some grade of the cancer which are higher grade cancer. We have to do papillary cancer or below glandular cancer. So any stage, any higher histological type or higher grade, we have to do para-aortic. Most 90% of the patients we are not supposed to do the complete pelvic and para-aortic. So morbidity is very, very less. There's hardly any lymphedema in the lower leg and all, which used to happen after lymphadenectomy, which is not happening at all. And patients do have very good survival.
Ma'am, I want to also ask you, before we get to the gynecologists, they are very eager to ask questions and some good questions. Ma'am, CA cervix is one of the commonest cancers in India. And now we have very effective vaccines available. We have now our own vaccine, the Servavac from, and we have Gardasil, the age-old Gardasil, against the 9 strain and 13 strains. Although the 13 strain vaccine is not available in India, very commonly the 9 one is available. Ma'am, your experience of treating CA cervix over the last 10 years, and has the vaccine changed the scenario in CA cervix?
See, I am very happy to tell all of you. Now women are so much aware about the cervical cancer vaccine, and there are so many students are coming to me for the cervical cancer vaccine, and we can give cervical cancer vaccine starting from the age of 13, age of 9, we can give the cervical cancer vaccine. So the incidence of cervical cancer which I have been seeing with my 30 years of practice, it's hardly 2 cancers you are getting in 1 year. Which were earlier we used to get 10 or 15 cases, now only 2 cases I am getting cervical cancer. And that too in early stage, because we have the pap smear was earlier thing, now we have that liquid based cytology examination and HPV DNA testing. We can pick up any cancer, cervical cancer anytime in very early stage, and the treatment is possible. And same for the endometrial cancer. Any postmenopausal women, there is a cutoff of endometrial thickness 4 millimeter. If they have endometrial thickness more than 4 millimeter, we always ask them to go for biopsy. And trust me, one more thing I would like to tell to all of you. There is no need to get them admitted in the hospital to take the biopsy. Only for the patient we are not able to take OPD people biopsy, they are getting admitted and they are getting hysteroscopic directed biopsy. With the people biopsy, we can 90% time we can pick up the CA endometrium, and we have the facility of frozen section. So immediately the day patients are coming to my OPD, they are so much worried up. They are sitting in my OPD and they say, doctor, everybody, all doctors are telling me, they make me scared that might I have got uterine cancer. I tell them this is just 1 hour of jog 15 minutes, I'll take your sample, another half an hour your report will be ready, and the frozen section report is right there, just to allay their worries. And if it is negative, then 70%, these frozen sections report are 70% correct. So I always tell them that if this is 70% correct, if it is negative, then highly unlikely the final report will come positive. So this is a real
In case of uterine prolapse, you use the mesh for the support. So you do it with uterus intact or you remove the uterus?
Dr. Kiran, this is a beautiful question. Actually, you can do both ways. The patients, I have seen patients with a congenital prolapse. 22 years old girl came to me with the prolapsed uterus. For that patient, you can put the mesh with intact uterus. There is no need to remove the uterus.
Okay, if recurrence occur, then what is next? Hysterectomy or again you repeat the procedure?
If recurrence is occurring, you can repeat the second procedure. If you have done pectopexy, you can do sacrocolpo. There is one more procedure, we call it sacrocolpopexy. So if pectopexy has been done, you can do sacrocolpopexy. If sacrocolpopexy has been done, you can do pectopexy. If nothing is working, then last resort is to remove it.
If patient is young, suppose, so what about her tubal status, fertility status? If patient is young, she has prolapse and you did hystropexy, then her fertility will
no. The thing is, when you are doing, when I am doing MASH procedure, sacrocolpopexy or pectopexy for a young girl, the tubes are not affected with that.
She can become pregnant.
Yeah. So many patients they are getting, they go ahead with this pectopexy procedure, they become pregnant and they deliver the baby with C-section. I will not tell them to deliver vaginally because it will put extra pressure on that mesh and mesh can be pulled down. So I tell them, you have this procedure, after 3 months you can get pregnant and we'll do the elective cesarean section.
Thank you.
In case of hystosacropexy, basically, though which patient are not getting naturally pregnant, after getting the hystosacropexy, they are getting naturally pregnant in young girls. It's a very good outcome with the hystosacropexy, and patient only have to deliver by cesarean section, and there is no affection on the fertility. And fertility is much more improved after hystosacropexy.
Hello, Usha. Very nice to know what a robotic experience. Of course, I fully agree that robotic surgery has revolutionized the era of laparoscopic surgery. And the surgeon is more comfortable, neither gets angry and neither gets tired. Dr. Viplab will fully agree. And but thank God, being a hardcore obstetrician, I am really very happy that neither laparoscopy, neither robotic has come into obstetrics.
The robotic is coffee with console. You can have your coffee, you do surgery. But of course, we cannot deliver the baby robotically. So robotic or lapro will never ever come to you.
Ma'am, something I would like to ask you and for benefit of everyone, and I would like Dr. Abha Parashar's comments also. Ma'am, you talked about malignancy and you talked about the importance of MRI. Ma'am, for all the uterine cancers, ovarian cancers, the modality of choice is MRI only, or there is a scope for ultrasound?
Yeah, the thing is, the ultrasound is a basic technique. Then MRI or PET scan, these are the advanced technology. So the thing is, which you are not able to see in ultrasound, definitely, like all malignancy patients with suspected malignancy, this is a protocol now. We have to do either the PET scan or MRI. So for ovarian cancer, we would like to find out the origin of the cancer. Maybe this is Krukenberg or maybe somewhere else, proper seedling of other cancer. So PET scan is the best. But for the uterine cancer or cervical cancer, we go ahead with the MRI. We want to find out the grade and the depth of invasion.
I would like to know Dr. Abha Parashar's comments on this, and also her comment regarding the follow-up. After you have operated the patient, do you do ultrasound or MRI? Ma'am, which one? Which modality?
MRI is ultrasound is considered to be a basic modality, since it is non-invasive. Patient is comfortable, so that is the primary thing to be done. anytime a patient is walking in. After that, if it is a malignancy, PET CT would be the ideal choice to see the spread of the cancer before the surgery is taken out. Post-op, again, ultrasound is the modality of choice, and of course, after a year, PET CT, just to know that it has not spread anywhere or no new development has happened.
So the whole idea of doing PET CT to find out the coexistence. Yes.
Particularly when PET CT is so cheaper, it's cheaper than CT whole abdomen.
I would like to come. I think Dr. Biplab had a comment.
I want to say some comment regarding the choice of modality for cervical cancer. One of my colleagues,
Dr. Moderator sir.
means this is the ultrasound is the basic. I mean, actually right. Basically, I have one of my colleagues. Here the ultrasound is stump carcinoma. Is a cervical stump carcinoma. He had on a cesarean section and post cesarean hysterectomy has been done. Long year back. Then she got in something nodularity in the ultrasound, but it cannot be diagnosed. She got a pap smear, she got a colposcopy, she got a cervical biopsy. Nothing has been diagnosed. And then the ultrasound, there is only a nodular lesion on the cervix. Then she got a PET scan. With PET scan and MRI, both diagnosed the stump cancer, cervical cancer. That's why you are saying that ultrasound is the basic modality. The precise modality, the PET scan and MRI scan, obviously.
What I want to know, and also I'll then come back to Dr. Abha, what percentage of cases are you missing on ultrasound? What percentage of cases of CS cervix, let us say, you will miss on ultrasound? Is it very sensitive? Is it very specific? Your comment.
Ultrasound will just let us know about the mass, but about the pathology or histopathology we will not be able to categorically say.
Is it a sensitive investigation?
It is sensitive because it is more comfortable, yes. But the specificity is definitely added on with further pap smears or tests.
Thank you. We will go to the table map which is going to test your not robotic skills, your theory skills, and they will also test you for your MRCOG and FRCOG. We come to Dr. JPS.
Nothing like that, ma'am. So that was a wonderful talk. And now talk us about the the worldwide. We know that especially in developed countries like US and Europe, breast, then endometrial cancers, then ovarian cancers, then finally the cervical cancers. But in low resources countries, I would not say that India is a low resource country, but in low resource countries, probably cervical cancers are more common as compared to the endometrial cancers. So is it because of the, the pap test and the HPV testing, which is widely available today?
Actually, so I'm sorry, what did you say last sentence?
So is it because of the pap test and the HPV testing, which is widely available today, the cancers of, the cervical cancers is less now?
Yeah, definitely, I have said already. So now anybody is coming to my OPD, I always offer them to go ahead for the pap smear if they can afford it, because pap smear and HPV DNA testing is too much difference in the cost. So if they can afford pap smear, or if they can afford HPV DNA and liquid-based cytology, if they can't afford, then I do pap smear for all my patients. Whoever is sexually active, more than 25, I always do pap smear for them. And the incidents are definitely decreasing.
Let us talk a little about uterine fibroids or the endometrial fibroids versus the polyps. See, we know the endometrial fibroids are never cancerous. But the polyps, you see, could be cancerous. So, polyps more than say between 5 to 10 centimeters, you need to remove them if they are causing symptoms and if probably, if there is a suspicion of cancer, especially in postmenopausal women.
See, first of all fibroids are non-cancerous. That is also not true, because the fibroid, if it is happening in older women and there is a big size of fibroid, and if it is degenerated sort of fibroid, we do LDH testing, we do MRI mapping, so that can give us the hint regarding sarcoma. So sarcomatous fibroids are also there, but the final histopathological examination is the only answer to find out whether this is a benign
So how common
fibroid.
is that?
Sarcoma, like
Postmenopausal?
in my practice, like hardly in 5 years of my practice, I get 2 patients of sarcoma.
5 years, just 2 patients?
2 patients. So it's very rare, no doubt about it. But when patient is having this and you have done surgery and you have vacillated without using endobag, it's a crime to do that. Because if you have not used endobag and you have upgraded the disease, one of my patients, I had used endobag, still she died after 6 months of doing surgery. And then she had from a doctor family, they investigated all root cause analysis. And luckily I was safe because I had used the endobag. So when it happens, you don't know. Like polyp size is not related with the possibility of cancer. So any size of polyp could be cancerous depending on the appearance of the polyp. That's the most important.
Do you need to remove a polyp if they are less than 5 centimeters?
5 centimeters, very big point. You mean to say 5 millimeter or centimeter?
5 to 10 centimeters, probably need to remove.
Okay. So 5 to 10 centimeter, definitely 100% sure.
Especially if they are causing symptoms.
Even the size of the polyp is 5 millimeter and appearance is not good and it is in the older age women. Even if it is asymptomatic, then also you are supposed to do it.
Right. Let's talk a little about the PID. See, the commonest cause appears to be chlamydial trachomatis infection, cervicitis, to staphylococcus, to florid PID. See, increase the risk of ectopic pregnancy by at least 4-fold. And effective vaccination, probably for chlamydial vaccination is under trial, and once available will have a dramatic impact on the frequency PID and ectopic pregnancy. Talk us through the PID, ma'am.
PID is very flared up PID is very uncommon. So if the patient underwent some surgical procedure and there was blood collection in the pouch of the gas.
PID is so common. It appears to be.
I am talking about the flared PID.
Yeah, florid you mean to say.
So if it is all flared up inside the abdominal cavity, then it's very rarely it happens. But of course, the mild to moderate PID, you may get many cases in the body.
Right. So finally, what about the future? The future of the robotic RAL. So miniature instruments with artificial intelligence seems to be the future of RAL today. What do you say, ma'am?
So this Da Vinci Robotic is already with this artificial intelligence, and this is already with the miniature
instruments already available?
Yeah, the miniature instruments, because we are abdominal surgeon, we have to do surgery through abdomen. So very many instruments will not be working. I don't think miniature instrument will come for robotic gynae or robotic general surgery. But of course, for the other fields, miniature instruments will come.
Finally, about biomarkers. In early detection of ovarian cancers, see, CA125 is widely used, combining with HE4 probably and with ultrasound, probably would enhance the diagnostic accuracy.
Definitely it enhances the diagnostic accuracy, but the thing is, whenever you see the report of CA125, the footnote is CA125 can be raised in any situation. So other diseases. So there is a cutoff of more than, if it is more than 200, then we start thinking about malignancy.
I thought that's 35.
That is what 35 is the normal, less than 35.
About 35.
Cutoff I am talking about the benign and malignant.
Okay.
So if it is more than 200, we start thinking of malignancy.
Need to combine with HE4 and thank you, ma'am.
Dr. Usha, I am Dr. Sarat Gopalan. I am a pediatric gastroenterologist at Rainbow Hospital. It's a pediatric. So I just wanted to know, do you have any indications for intervention in your field in a pediatric fraternity? They not be gastro, not my field, gastroenterology.
Pediatric malignancies.
No. Pediatric, anything pediatric.
Gynaecology.
Pediatric gynecology, I just wanted to know. Because
Pediatric
I'm a
surgeons
pediatric
are
gastroenterologist.
But pediatric surgeons are there.
Yes.
I think Dr. Noor is there in Max Hospital. He is pediatric surgeon.
Yes, Noor and Dr. Anubhav Krishna are there. But in Rainbow, we have Niaz and Dr. Chandru there. I mean, we have people. What I'm trying to say is that when you look at interventions, for pediatric gastro indications, do you have any?
Gastro, I'm not aware. I don't think.
That's what I want.
I'm sorry.
For gastro, there are no indications.
Dr. Usha, nice meeting you after a long time. A nice talk and so.
After the CME, I'm hoping one poem from you.
Thank you so much. मैं अभी ये कहना चाह रहा था, एक सवाल आया था कि ऑब्स्टेटिक्स में रोबोट्स का कोई रोल नहीं है। इससे अभी हम इतने दूर भी नहीं हैं। मैंने थोड़ा कोई 15-20 साल पहले एक किसी बंदे को अपने ही उससे एक कार्टून बनाते हुए फिर उसके साथ टेबल टेनिस खेलते हुए देखा था। It was 15 years back. तो आते हुए टाइम में ऑर्थोपेडिक्स में ऑब्स्टेटिक्स में क्या होने वाला है, वी कैन इमेजिन। यहाँ बैठे हुए हम मंगलयान पे ऑपरेट कर रहे होते हैं, चंद्रयान पे ऑपरेट कर रहे होते हैं। So we can be doing lot with robotics in obstetrics also. हम robotic उन बच्चे के साथ खेलते खेलते उसको बाहर ला सकते हैं। My only single question is, when we were students, we had a lot about Lee cords operation. Is it still being done? And is there any robotic superiority on that?
Leaford surgery is a vaginal surgery.
Yeah.
So nobody can do it with robot. I mean, maybe in the future somebody can do it. But I am not very fond of Leaford surgery. But of course, the patients who are 80 years old, more than 80 years, not fit for laser surgery, and they have got a prolapse, we do offer them to go for Leaford surgery.
But robots are our very good friends.
Yeah.
So let's master them. Thank you so much.
That's what I am trying to do.
Friends, are there any other questions anybody wants to ask?
Dr. PK.
Okay, if there are no more questions, I would like Dr. Shirin Masi ma'am to summarize this wonderful CME for us. And I would also like to know from her when to refer cases to Dr. Usha and Kumar ma'am, apart from referring cases to her and to Dr. Kawaljeet Bansal and to Dr. Bipla Mukhopadhyay. What is the specific indication of sending those cases to ma'am? I'm sure you must be supporting ma'am. So you comment on that.
Pain abdomen, women come to the physicians also, if they are family doctors. Get ultrasound done, if there is any reporting regarding endometriosis or geomas or something, directly refer it to Dr. Usha, and then she will decide what to do. And for us, once a gynecologist we specify, especially the specified robotic cases, we refer to her for GPI. And her lecture is really very clear. Even for the physicians,
Videos were very good.
it was very clear. And the questions were very interactive. The session was really good. And Dr. Kalra's